Hello friends, let us learn a new topic today about hyperprolactinemia. Hyperprolactinemia, it is the most common pituitary hormone hypersecretion in both men and women. This is women and men. The most common cause of hyperprolactinemia is pituitary adenoma. And in this pituitary adenoma, prolactin levels will be more than 200 microgram per liter. So let us learn about the etiology of hyperprolactinemia. Increased prolactin. Number 1, it can be physiological hypersecretion, where it occurs physiologically in our body. It is not associated with any disease. That include number 1, pregnancy. There is increased production of prolactin for milk production and even in lactation. And then in chest wall stimulation. So this is chest wall stimulation. And this hyperprolactinemia, it occurs in sleep. When you sleep, there is increased prolactin more than the normal, and even in stress. So these are the physiological states where hypersecretion of prolactin is seen. And some hypothalamic. And then the next cause is hypothalamic and pituitary sac damage. So what happens? First let me tell what happened and then I'll tell you. This is the pituitary I'll draw it, okay. This is the sac of the pituitary and this is the pituitary gland. And here there will be hypothalamus. So from the hypothalamus to the pituitary, there is dopamine production. This dopamine will inhibit prolactin, okay, secretion. But here in hypothalamic and pituitary sac damage, what happens? In hypothalamic and pituitary sac damage, there will be no dopamine to the pituitary. So because of no dopamine to the pituitary, there is increased prolactin because of absence of inhibition. So what are the causes? Causes include tumors like pharyngioma, and then suprasellar pituitary tumor. Suprasellar pituitary mass can cause this, and sometimes even meningioma can cause this thing, and dysgerminomas, and also some pituitary metastasis. All these will compress the pituitary sac and thus damage it, and thus there is no dopamine. That is one. And then sometimes empty cella syndrome can also cause the pituitary sac damage. Then lymphocytic hypophysitis, and then it can be due to adenoma with sac compression, where there is compression of sac due to adenoma. And then it can be due to granulomas which infiltrate the sac, or it can be due to Rathke cyst, and then irradiation, and sometimes trauma in which there can be pituitary sac section. The pituitary sac can be cut into two, or there can be suprasellar surgery. In this suprasellar surgery, there may be trauma to the sac. So all these are the causes for hypothalamic pituitary sac damage. And then third, there can be pituitary hypersecretion. Pituitary hypersecretion can be due to prolactinoma or acromegaly, where there is increased secretion of prolactin from the pituitary gland. And the fourth one, it can be due to systemic disorders. The systemic disorders like the chronic renal failure, where there is I don't know why, and also hypothyroidism, because TSH will also inhibit prolactin. Because of that, there is no inhibition, so that there is increased prolactin, and it can also be due to cirrhosis and pseudocysis and epileptic seizures. So all these can also cause hyperprolactinemia. Then the most important and the most common it is due to hyperprolactinoma, and after that it can be due to drug-induced hypersecretion. In drug-induced hypersecretion, number 1, it is dopamine receptor blockers. Some drugs may block the dopamine receptors. So these dopamine receptor blockers include, number 1, antipsychotics like risperidone, then phenothiazine, chlorpromazine, next perfenazine, then butyrophenones, then haloperidone, thioxanthines, and metoclopramide. So all these will block the dopamine receptor. Okay, now the second type is, I'm sorry for the interruption. I'm sorry. Now the second type is dopamine synthesis inhibitors. Here there is inhibition of dopamine synthesis. So the most important type is alpha methyl dopa. Then catecholamines. Catecholamine depleters also inhibit dopamine, like reserpine. Then sometimes opiates also inhibit it. Then sometimes H2 antagonists. The H2 antagonists like cimetidine, ranitidine, and sometimes imipramines. The imipramines like amitriptyline and also amoxapine. And then serotonin reuptake inhibitors. The serotonin reuptake inhibitors like fluoxetine, and also calcium channel blockers like verapamil, and then estrogen, and then thyrotrophin releasing hormone. So all these are the causes of hyperprolactinemia. So let us learn how this hyperprolactinemia presents. The major clinical features of hyperprolactinemia include, there is a triad, that is amenorrhea, galactorrhea, and infertility. Then if this hyperprolactinemia, if it develops before menarche, then the patient has primary amenorrhea. If it develops after menarche, first it leads to oligomenorrhea, and slowly it progresses to secondary amenorrhea. Okay, because of hyperprolactinemia, there is decreased vertebral bone mineral density. Why is this occurs? Because it is associated with hypoestrogenemia, because whenever there is decreased estrogen, then there is decreased bone density. Okay, galactorrhea is seen, and we will learn about it in a few minutes later. But they also complain of decreased libido, and there is weight gain, and also mild hirsutism. All this is seen in females. Then what happens if there is hyperprolactinemia in males? In males with hyperprolactinemia, they also show decreased libido, infertility is seen, and sometimes visual loss can also be seen because of compression of optic nerve. Optic nerve compression can cause visual loss. Okay, whenever there is gonadotropin suppression, prolactin suppresses gonadotropin, that will lead to decreased testosterone, and it also causes impotence and oligospermia. Because of decreased testosterone, there is osteopenia, decreased muscle mass, decreased beard growth. So these are the different clinical features which are associated with hyperprolactinemia. Okay, now let us learn a few sentences about galactorrhea. Galactorrhea is inappropriate discharge of milk containing fluid from breast. Normally it should not discharge. Generally milk is seen whenever after the birth of the baby, but here inappropriate discharge of milk containing tumor from the breast. It is abnormal if it persists for more than 6 months after childbirth, or it persists after discontinuation of breastfeeding. Okay, this galactorrhea, it can occur either spontaneously or it can occur whenever we apply pressure on the nipple. So by nipple pressure also it can be elicited. Okay, it can occur in both men and women. This galactorrhea can occur in both men and women. It can vary in color and consistency. Mammography is done. So what consistency can it be? It can be transparent, it can be milky, or sometimes you can even see bloody discharge from the nipple. So whenever there is bloody discharge, then do mammography or ultrasound. Okay. Galactorrhea is also associated with acromegaly in 1/3 of the patients. Treatment is manage the disorder. Okay, this is later. So now let us come back to laboratory investigations of hyperprolactinemia. So in hyperprolactinemia, we do basal and fasting morning prolactin levels. Okay, the normal value is less than 20 microgram per liter. Okay, here in this both false positives are also seen and also false negatives are also seen. Then because of assay artifacts, if there is increased prolactin levels to more than 1000 microgram per liter, 1000, okay, let me write 1000 microgram, I forgot one more zero, shall write it again. If there is increased prolactin of more than 1000 microgram per liter, in such situations, because of assay artifacts, there may be false negative results. Sometimes false positive lesions are also be seen because of aggregated forms of circulating prolactin. The circulating prolactin may lead to this false positive results. Okay, so this is the laboratory investigation that you do for hyperprolactinemia. Then how do you treat hyperprolactinemia? Treatment depends on the cause. The aim of this prolactinemia treatment is to normalize the prolactin levels and to decrease the symptoms. Okay, and also preserve bone mass density. That is important. So you can give dopamine agonists. Agonists can be given for most causes of hyperprolactinemia. If it is due to drug induced, then you will have to withdraw the drug. That is the best treatment for this prolactinemia. And treat the systemic conditions. As I have already shown, there are systemic conditions like hypothyroidism, renal failure, all that should be treated accordingly. Hypothyroidism by thyroid replacement therapy, and chronic renal failure by renal replacement therapy by dialysis. So chronic renal disease, they should be treated accordingly. If there is prolactin, if there is mass lesions, they should be resected. And if there are granulomatous infiltrates, all the granulomatous infiltrates, they respond well to glucocorticoids. So glucocorticoids are given. Okay, so all these is done for hyperprolactinemia. So thank you guys for watching my lecture. In my next class, I will explain about prolactinoma. Thank you for watching my lectures. Thank you.